If that artery isn't healthy, it won't dilate as much. And then you use a sort of control agent, GTN in this case, to measure what it will do maximally. And if you use that approach, what you find is actually it's a pretty good measure of of predicting events, and you can use that approach even in patients who are quite late in the process. So what this shows here is the analysis studying the evaluation of the association between coronary or peripheral endothelial function and cardiovascular events. And in both cases, you can predict quite well who will or won't develop heart disease or the cardiovascular event. You might need to use a different approach late. And that approach is looking at the pathology of the artery. And in that case, you look at things like calcification, for example. You can use X-rays to look at calcification within the artery wall. So this is a narrowing here. And in that narrowing, you also find co-localized calcification. And if you use calcification, coronary calcification, as a way of, with the Framingham risk score, what you can do is within those individuals at low risk or at high risk, you can stratify them better. So even within the group that had a notional risk of less than 5%, you can find individuals and groups in which the risk is up to 20%, 19 to 20%. And in those notionally with a very high risk, you can also find groups that have relatively low risk. So this is looking at the artery wall rather impugning risk factors are going to help you. And the other thing is to be able to better predict